You know how sometimes tackling something really complex, maybe it's a new skill or a tough project at work, it feels like you're just lost in a jungle, right? No map, no clear path.
Yeah, exactly. You're feeling your way around, hoping you don't make a big mistake.
Right. Now, imagine that feeling, but the stakes are, well, incredibly high. We're talking about intricate surgery.
Mm,
Today, we're diving into a set of guidelines that act like that essential map for a really critical surgical
a
procedure.
much-needed map, I'd say.
Welcome to the deep dive. We unpack complex ideas, try to distill them down, and hopefully give you those aha moments.
That's the goal.
Today, our focus is on the frankly fascinating world of minimally invasive surgery, specifically inguinal hernia repair.
A very common procedure, but one with nuances.
Exactly. And this isn't just about how to do the surgery mechanically, it's about how to do it safely, effectively, and crucially, with a standardized approach.
Yeah, one that helps everyone, from the junior surgeon just learning the ropes of laparoscopy, to the senior surgeons teaching them.
Our deep dive today is grounded in a really key paper from surgical endoscopy. It lays out 10 golden rules for a safer procedure in minimally invasive inguinal hernia repair.
And it's more than just a list, isn't it? It's distilled expertise designed to make something complex, safer, and more reproducible.
That's a great way to put it.
So our mission today is to walk you through these foundational ideas and then really get into the 10 rules themselves.
We'll explore not just what they are, but really dig into the why. Why are they so vital?
Exactly. How do these guidelines provide that clear framework? How do they cut down on variability and ultimately improve patient outcomes, especially now with more and more surgeons adopting these advanced techniques?
Right, you'll get a real insight into the kind of thinking that goes into surgical safety and standardization.
And specifically, how senior laparoscopic surgeons can use this to effectively teach junior surgeons and how those junior surgeons can gain confidence and competence in these pretty intricate procedures.
Okay, so let's start by setting the stage a bit, looking at the journey of hernia repair itself. Because understanding the history really helps appreciate why these golden rules are, well, kind of revolutionary.
It provides context, definitely.
For decades, I mean, many decades, open surgery, was it? The gold standard for inguinal hernia repair.
Yep, well understood, effective for sure, passed down through generations.
It worked, no doubt. But like any established method, it had trade-offs, right? Particularly for the patient.
Oh, absolutely. Longer recovery times, often more significant post-op pain because of the larger incisions, more time off work, the usual downsides of open surgery compared to minimally invasive options.
So what's fascinating then is that even when laparoscopic techniques started showing clear benefits, like you said, less pain, faster recovery, the adoption wasn't exactly overnight.
No, it definitely wasn't. Which does make you ask, right, why the hesitation, the patient advantages seem so obvious on paper.
Yeah, what was the holdup?
Well, it wasn't lack of desire, I don't think. It was more about the inherent challenges of shifting, going from a familiar open approach to a totally new way of operating.
Yeah.
Especially for something surgeons had done one way for years, maybe decades.
Okay, so what were those main challenges?
I think one of the biggest hurdles was this fundamental shift in anatomical perspective.
How so?
Well, in open surgery, you're looking at the groin from the outside in. The layers, the structures, it's familiar territory visually and tactily.
Okay.
With minimally invasive, suddenly you're inside looking at the posterior aspect of the groin. It's a completely different view.
Like looking at a map upside down.
Kind of like that, yeah, or inside out. It's a fundamental reorientation of your spatial understanding. It takes, significant cognitive effort and specific training to master that view.
So for a senior surgeon, that meant unlearning years of ingrained visual cues.
Exactly. And for a junior surgeon, it was like learning a whole new anatomical language from scratch based on a 2D screen image.
And that wasn't the only hurdle, was it?
No, definitely not. Compounding that was the need for advanced laparoscopic skills.
Right, operating with long instruments through small holes, looking at a monitor.
Yeah, think about it. Exceptional hand-eye coordination, ambidexterity, judging depth from a flat screen. These aren't skills you pick up overnight, or skills that were necessarily part of traditional open surgical training.
So that created a barrier to entry.
A big one. It limited how quickly it could be adopted broadly, and it made it tough for even really skilled senior open surgeons to just switch over and start teaching laparoscopic techniques effectively.
Sort of a chicken and egg situation. How do you train new people if the experienced ones aren't fully proficient yet?
Precisely. You needed something to bridge that gap.
And that's where robotics came in. The paper highlights robotic-assisted surgery as a pivotal innovation.
Yeah, I think that's fair to say. It's a real game changer in many ways. It started to break down some of those barriers we just talked about.
How did it do that? It wasn't just automation, right?
No, not at all. It fundamentally enhanced the surgeon's capabilities. It made minimally invasive surgery, frankly, more intuitive and maybe easier to learn compared to pure laparoscopy.
What were the key advantages?
Several big ones. First, enhanced 3D visualization. That immediately helps overcome the depth perception issue of 2D screens.
Okay, that makes sense.
Then, wristed instrumentation. The robotic instruments mimic the human wrist's range of motion, allowing for much more dexterity in tight spaces compared to rigid laparoscopic tools.
Ah, so more like operating with your own hands again.
Exactly. It felt more natural. And the platform itself often offered a more stable camera, tremor filtration, things that just flattened that steep learning curve for advanced laparoscopic skills.
Less like operating with chopsticks in a box.
Much less, yeah. The tools felt like an extension of your hands again with this crystal clear, magnified 3D view.
So this combination of factors led to more surgeons adopting minimally invasive techniques.
Definitely. A rapid and significant increase. You had experienced surgeons finding it easier to transition, and new surgeons learning these techniques from the get-go.
Which brings us back to the core need.
Yes. With this upsurge, more surgeons doing these complex procedures, the need for a universally understood, standardized, and critically safe approach became absolutely paramount.
Especially for teaching, right? How do senior surgeons effectively pass on these skills to junior surgeons safely?
Exactly. Without a common framework, a shared language, clear guidelines, the risk of inconsistency, complications, and just an inefficient learning process goes way up.
So pulling this all together, what does this evolution mean for, someone listening, maybe a medical professional, a student, or just someone curious about how surgery gets better?
Well, it means that as innovation makes complex procedures more accessible, the focus has to shift, doesn't it?
From can we do it
To how do we make sure we do it consistently well and safely every single time? It's about taking the variability out, putting reliability and patient safety front and center.
Right. So in this world of complex tech and surgery, how do you guarantee those benefits consistently without compromising safety?
And that's where clear, well-defined guidelines like these 10 golden rules come in. They minimize that variability, reduce human error, and offer a solid framework for both practice and, really importantly, for teaching.
A common language, a shared understanding.
Indispensable when senior surgeons are mentoring junior surgeons. It allows for that structured, step-by-step learning. Specific steps can be taught, watched, evaluated, refined.
So it elevates the standard of care across the board.
That's the idea, making sure the promise of minimally invasive surgery is delivered safely and consistently for every patient.
Okay, so before we get into the rules themselves, the paper by authors like Claus and Felix doesn't just jump in. It sets up two foundational concepts first.
Yeah, think of them as the roadmap, the core principles before you get to the step-by-step direction.
The philosophical bedrock, maybe.
Yeah, something like that. The deep anatomical understanding you need before you start applying the rules. Essential for safe practice, especially for junior surgeons trying to get their head around this complex internal view.
These concepts aren't just theoretical, though.
Oh no, not at all. They come from meticulous observation, anatomical study, loads of experience from expert laparoscopic surgeons who've spent years refining these techniques.
Designed to bring clarity to a potentially confusing area.
Exactly. Clarity and objectivity.
Okay, concept number one, the critical view of the myopectineal orifice. MPO. Sounds like a bit of a mouthful.
It does, but it's an incredibly powerful idea. And what's really interesting is the direct link, the analogy they draw, to the critical view of safety in gallbladder surgery.
I know that one. That really changed things for bile duct injuries, didn't it?
Absolutely revolutionized it. It standardized dissection, demanding clear identification of the cystic duct and artery before any cutting, dramatically reduced those awful injuries.
So the MPO concept applies that same rigorous safety-first thinking to hernia repair.
Precisely. It's about achieving a specific, standardized visual endpoint during the dissection. Before you even think about putting the mesh in, you have to achieve this critical view.
A non-negotiable checkpoint.
Totally. The core idea is getting this view confirms you've dissected the whole area properly, and crucially, you've unambiguously identified all the key landmarks.
So no surprises later, No misidentifying things.
Right. And you don't accidentally place mesh over a small hidden hernia defect that you missed because you didn't expose everything fully.
The safety implications seem huge.
They are. Standardizing this view drastically reduces the risk of injuring structures you can't see clearly. And for a junior surgeon, it gives them an invaluable, clear, objective target for their dissection.
Takes away some of the guesswork.
Exactly. They know precisely what they need to see before moving on. It makes a daunting task more manageable, less anxious. A senior surgeon teaching this would absolutely hammer this point home. Show me your MPO. Is everything clear? Only then do we proceed.
It empowers them with a benchmark. Okay, now for the second foundational concept. Visualize an inverted Y and the 5 triangles. Sounds like geometry class.
Huh, it does a bit. But it's actually a brilliant mnemonic, a mental map for navigating this really complex groin anatomy safely.
So it helps surgeons know where critical structures are without having to dissect every single tiny nerve.
Exactly. Trying to dissect everything out can actually cause more harm, increase operative time, raise the risk of injury.
Yeah.
This system is like a conceptual shortcut, a navigational chart based on key landmarks.
Okay, break down this inverted Y for us. What forms it?
Correct. So picture the posterior groin. The Y is formed by 3 essential structures you absolutely need to be aware of.
Go on.
First, the inferior epigastric vessels. Think of them running vertically across. They form the central stem of the inverted Y.
Okay, got the stem.
Second, the vas deferens. In males carrying sperm, it loops over those vessels. That's one upper arm of the Y.
Arm number 1?
And third, the spermatic vessels supply the testicle they run alongside the vas deferens. That's the other upper arm.
Okay, so epigastrics as the stem, vas, and spermatic vessels as the diverging arms. Inverted Y. Clear.
Now, the next step is key. Mentally add a horizontal line across the middle of this Y. That line represents the iliopubic tract.
A strong ligamentous band.
Exactly, a key anatomical divider. And where this horizontal line intersects the Y, it creates 5 distinct anatomical triangles.
And these aren't just random shapes.
Not at all. Each triangle highlights areas with specific anatomical stuff to worry about. They guide your dissection and mesh placement by showing you where the danger zones are critical nerves, major vessels, and where it's relatively safer to work.
So some triangles might contain nerves causing chronic pain if injured. Others, major arteries.
Precisely. It maps out the risks.
The paper also mentions 3 zones.
Yeah, they further break down the operative field into 3 zones to guide the dissection systematically. Zone 1 laterally, likely nerve-rich. Zone 2 central, where the main repair happens. And Zone 3 medially and inferiorly, with those crucial vessels and cord structures.
Okay, so what's the big takeaway from the inverted Y, the triangles, the zones?
It's the core philosophy behind the rules. It ensures surgeons stay oriented, stay in the right anatomical plane, know where they are relative to vital structures, and most importantly, actively avoid the things that cause serious complications, bleeding, chronic pain, fertility issues.
So for a junior surgeon learning this
mental map is indispensable. It turns a confusing 3D mess into something navigable, gives them confidence, clarity. It's the difference between fumbling blindly and following a clear path. A senior surgeon would constantly be saying, okay, which triangle are we in now? What are the risks here?
Okay, so with those foundational concepts, the critical view of the MPO and this anatomical map of the inverted Y and triangles firmly in our minds, let's dive into the 10 golden rules themselves.
Right. These are the step-by-step directions, the distilled wisdom for achieving that safe, reproducible repair we've been talking about.
Designed to make the complex manageable, especially for teaching and learning.
Exactly. And you'll see how each rule really builds on that anatomical understanding we just covered. It translates theory into concrete actions.
So for junior surgeons, it's like a checklist, a framework.
Yeah, reduces uncertainty, lets them focus on mastering specific steps. And for senior surgeons, it's a standard language for teaching, for evaluating progress, ensures consistency.
Okay, rule number 1, the very beginning of the surgery.
Yep, establishing the operative field. Absolutely fundamental.
The core rule is ensure adequate working space and proper exposure. Sounds simple, but critical.
Absolutely critical. It's the foundation. If you don't get this right, everything else becomes harder and riskier. Insufficient space, poor exposure, it compromises visibility, limits your instrument movement.
Sets you up for failure almost.
Pretty much. You need room to work safely.
So how does this apply differently for, say, TAPP versus TTP?
Good question. For TAPP, the transabdominal approach, where you go into the abdomen first, the rule is specific. Incise the peritoneum, at least 4 centimeters above the deep inguinal wing.
Why 4 centimeters?
That specific distance gives you enough flap lengths later to cover the mesh properly without tension. And the flap needs to be wide from the ACIS, at hip bone point, across to the medial umbilical fold. Wide exposure is key.
Okay. And for TEP, totally extraperitoneal.
There, you're creating the space directly outside the peritoneum using blunt dissection, maybe with the scope itself or a balloon dissector. The goal's the same, though. Create a large, clear working cavity.
A common pitfall here for learners might be making the space too small.
Very common.
Yeah.
They might be hesitant, but a cramped space just makes everything awkward, frustrating, and increases the risk of bumping into things you shouldn't. A senior surgeon will really push for generous space creation. Give yourself room to breathe.
Makes sense. Get step one right.
Absolutely.
Okay, rule number 2. This one gets into the dissection technique itself. Dissection follows the peritoneal plane.
Yes, and this is about protecting vital structures with a very specific technique. It dictates that you must keep the fatty tissue attached to the inguinal floor, not stuck to the peritoneum you're lifting up.
So as you separate the peritoneum, leave a thin layer of fat on the muscle underneath, like a protective blanket.
That's a great way to think about it. Exactly.
And why is that so important? What does that fatty layer protect?
Two main things. First, nerves. Important nerves in zone 1 that, if injured, can cause chronic pain. Think lateral femoral cutaneous nerve, genitofemoral nerve branches.
Okay, nerve protection. What else?
Second, vessels, specifically the inferior epigastric vessels in zone 3. Keeping that plane helps you stay away from them and avoid bleeding.
Now this is where it gets interesting, right? This rule highlights a difference from open surgery.
Big time. And it's a critical teaching point. In open surgery, sometimes you'd actively look for and dissect out nerves. Here, the emphasis is on avoiding systematic nerve dissection.
To reduce chronic pain.
Precisely. The goal is to identify and protect the nerves by staying in the right plane, not necessarily to expose them fully, which risks irritating or damaging them. Getting that balance right is key for a junior surgeon.
So the senior surgeon would be guiding them, stay superficial here, leave that fat down.
Exactly. It prioritizes long-term patient comfort. Fix the hernia, yes, but minimize the chance of trading it for chronic pain.
Rule number 3, extend the dissection. This sounds like it relates back to rule 1 and getting enough space.
It does, but it's specifically about ensuring enough room for the mesh and preventing recurrence. The rule states, dissection needs to be extensive, reaching the pubic symphysis, that front pelvic joint, and going at least 2 centimeters below it.
Not just stopping at the hernia defect.
No, much wider. You need that broad exposure.
And the rationale, why go so far down?
2 key reasons, both critical for a durable repair, especially for learners to grasp. First, mesh accommodation. You simply need enough room to lay down a large mesh, typically 10 by 15 centimeters, flat without wrinkles.
Okay, makes sense. Second reason.
Overlap for recurrence prevention. This is huge. The mesh needs to overlap the potential weak spots, the direct and femoral hernia spaces, by at least 3 to 4 centimeters in all directions.
Like putting a big patch over a hole, not just covering the hole itself.
Exactly like that. If your dissection isn't wide enough, you can't get that crucial overlap, and the hernia is much more likely to come back at the edges.
And this is a common issue for less experienced surgeons, not dissecting widely enough.
Absolutely. They might focus only on the visible hole. A senior surgeon will constantly reinforce these landmarks and measurements. See the pubic bone? Now go 2 finger breadths below it. That's your target.
It's about building a robust, lasting repair.
Precisely. Preventing that frustrating recurrence down the line.
Rule number 4. Visualize the external iliac vein. This sounds like a specific safety check.
It is, a critical one. The rule is blunt. Visualizing the external iliac vein in zone 3 is mandatory. You have to see it clearly.
And why is seeing that specific vein so important?
Because that's the key step to ensure you haven't missed a femoral hernia.
This can be tricky, right? Subtle.
Very subtle. Easily overlooked if you don't specifically expose and examine that area around the external iliac vein. If you miss a femoral hernia, you're leaving a problem behind.
Which could lead to complications later, another surgery.
Exactly. Potential emergency surgery if it incarcerates or strangulates, or just the need for a second operation. So this rule acts as a quality control checkpoint.
A stop and check moment during the operation.
Perfect way to put it. The senior surgeon would guide the junior. Okay, inguinal part done. Now let's deliberately look for that vein. Are we absolutely sure there's no femoral component hiding there? It emphasizes thoroughness.
All right, rule number 5. Parietalize the cord elements. That word parietalize sounds very specific. What does it mean in practice?
It describes a really crucial, delicate maneuver. The core rule is Dissect the peritoneum off the spermatic cord structures until you clearly see the vas deferens crossing over the external iliac vein in zone 3.
So parietalize means separating the lining, the peritoneum, away from the cord structures.
Yes. Carefully peeling that peritoneal layer back towards the abdominal wall, leaving the cord structures, the vessels safely attached to the deeper posterior wall. Keep them undisturbed.
And why is this meticulous dissection so vital? What are we protecting?
Critically important structures. First, the vas deferens itself, essential for male fertility. Damage here is obviously a major issue.
Okay, reproductive structures. What else?
Second, the major blood vessels in the infamous triangle of doom. This area contains the external iliac artery and vein. Injuring those can cause catastrophic bleeding.
So getting this parietalization wrong has serious consequences.
Potentially devastating. Testicular atrophy if you damage the stromatic vessels, major hemorrhage if you hit the iliacs. This rule guides surgeons, especially learners, through a high-risk zone with a very precise technique.
Requires a gentle touch, I imagine.
Very much so. Slow, careful, deliberate dissection. The senior surgeon would demonstrate this meticulously. Gentle sweeps. Keep the cord safe. Reveal. Don't grab.
Rule number 6 deals with a practical challenge. Large hernias. It says prioritize safety over completeness.
That's the essence of it, yes.
Yeah.
When you're dealing with a really big hernia sac, one that goes way down into the scrotum perhaps, the rule advises that it's often safer to cut the sac and leave the discal part behind, rather than risking injury by aggressively trying to dissect the whole thing out.
So you don't try to pull the entire sac back.
Not if it's large and adherent. The rationale is a really important clinical trade-off.
What's the trade-off?
A potential postoperative pseudohydrocele, basically a fluid collection where the leftover sac is much easier to manage and far less harmful to the patient than a hematoma, a blood clot, or, even worse, an injury to the spermatic cord caused by overly aggressive dissection.
Trying to get that last bit out risks damaging the vas or vessels.
Exactly, especially with chronic adherent sacs. The risk of injury goes way up. So this rule is about surgical wisdom, knowing when not to do more.
That's fascinating. It prioritizes avoiding serious complications over achieving a perfect anatomical result that might carry higher risk.
Precisely. It's a nuanced decision, requires judgment. And it's a key lesson for junior surgeons: learn restraint, recognize the limits of safe dissection. A small fluid collection usually resolves. A damaged cord or major bleeding is a serious failure.
Patient safety first.
Always.
Moving on to rule number 7. Explore for cord lipoma. What's a cord lipoma and why is it important?
A cord lipoma is basically a collection of fatty tissue, often peritoneal fat, that travels down alongside the spermatic cord into the inguinal canal. It's not part of the hernia sac itself, but it can look like one or be associated with one.
Okay, so the rule is to actively look for these.
Yes, always thoroughly check the deep inguinal canal for one. And if you find one, the rule is clear. It must be dissected free and completely reduced, pushed back out of the canal.
Why? What happens if you leave it?
An unaddressed cord lipoma is a known but often missed cause of hernia recurrence.
Really? How does a piece of fat cause the hernia to come back?
It can act like a plug, preventing the mesh from sealing properly against the abdominal wall. Or it can just create a persistent bulge or point of weakness that allows the hernia to reform around it later. It basically undermines your repair.
So it's about comprehensive assessment, looking beyond the obvious defect.
Exactly. Make sure you address all contributing factors. A senior surgeon would teach, even after you deal with the sac, sweep your instrument through the canal, feel for any fatty lumps. Don't ignore them.
Meticulous attention to detail, preventing future problems.
Oh, that's the essence of it.
Rule number 8 brings us to the mesh itself. Use a large mesh. How large are we talking?
The rule recommends a mesh large enough to cover the entire myopectoneal orifice, MPO, with at least a 3 to 4 centimeter overlap in all directions beyond the hernia defect.
And in practical terms?
That usually means a mesh around 10 by 15 centimeters.
That sounds pretty big. Why so large?
Because you need that significant overlap to reinforce the entire weakened area, not just plug the hole. It's fundamental to preventing recurrence. A small mesh just won't provide durable support.
Like that small Band-Aid analogy again.
Exactly. And there's a crucial caveat, too. Make absolutely sure the peritoneum doesn't get trapped or wrinkled behind the mesh when you place it.
What happens if it does?
It can cause chronic pain, fluid collections called seromas or adhesions. You need the mesh lying flat against the muscle and fascia.
So getting the size right and deploying it correctly is key. Another area where learners might struggle.
Definitely. Underestimating the size needed or having trouble unfolding and positioning such a large mesh in that confined space are common issues. Senior surgeons really emphasize that 3-4 centimeter overlap rule and check placement carefully. Is it flat? Good overlap everywhere, no wrinkles.
Building a strong, lasting foundation.
That's the goal. Comprehensive reinforcement.
Rule number 9, mesh fixation isn't always necessary. This might surprise some people, right? Isn't mesh always tacked down?
That used to be the common practice. Lots of tacks or staples. But understanding has evolved. The rule now states that for many, perhaps most, standard minimally invasive inguinal hernia repairs, mesh fixation is actually not required.
Why not? Doesn't it move?
If it's placed correctly in the preperitoneal space, it's held in place by the pressure from the abdomen, especially once the peritoneum is closed over it and TAPP or the CO2 is released. The pressure keeps it stable.
Challenging the more is better idea.
Very much so. However, the rule acknowledges that sometimes fixation is needed, maybe for very large defects, or if there's tension or specific patient factors.
And if you do need to fix it,
Then the recommendation is to use a limited number of tacks. And critically, you must strictly avoid putting those tacks in the high-risk areas, the triangles of pain, where major nerves lie, and the triangle of doom with the major vessels.
because tacking in the wrong place can cause serious problems.
Absolutely. Chronic neuropathic pain from hitting a nerve is a devastating complication. So if you fix, be precise, be minimal, and know your anatomy inside out. Avoid those danger zones.
It's about achieving stability without causing new problems like chronic pain.
Exactly. A refined technique focused on long-term patient quality of life. A huge teaching point.
And finally, rule number 10, deflate under direct visualization. This concerns the very end of the surgery.
Yes, the last crucial step. As you let the CO2 gas out, the gas that created your working space, you must watch the mesh directly with the scope.
Why is watching it as the pressure drops so important?
Because as the space collapses, the mesh can potentially fold, roll up, or shift out of position. If you're not watching, you won't see it happen.
And if it folds or moves?
That compromises the repair. It can lead directly to recurrence. All that careful work undone in the last few seconds.
Wow. So vigilance is needed right until the very end.
Absolutely. The operation isn't over until that mesh is secure in its final resting place. For TAPP procedures, they also recommend suturing the peritoneal flap closed rather than tacking it.
Why suture instead of tack?
Again, to avoid potential nerve injuries from tacks placed in the peritoneum. It's consistent with that theme of minimizing chronic pain.
So this final rule really underscores that even a minor oversight at the end can ruin the whole thing.
It does. A senior surgeon will insist, keep your eyes on the mesh as the gas comes out, make sure it stays flat, don't rush this. It secures the integrity of the entire repair.
Okay, so we've walked through all 10 golden rules. We've seen the anatomy, the techniques, the safety checks. What's the big picture impact of this standardized anatomy-based approach?
Well, connecting it all up, this framework makes the whole procedure significantly safer and much more reproducible. It really mirrors what the critical view of safety did for gallbladder surgery, clear steps reducing complications dramatically.
Building a predictable path to success.
Exactly. Reducing that variability between surgeons, ensuring a consistently high standard of care, regardless of who's holding the instruments, assuming they follow the rules.
And that's huge for teaching, isn't it?
Absolutely vital. Senior surgeons now have this common, evidence-based method to mentor junior surgeons. It's structured, measurable, provides clear objectives, allows for concrete feedback.
Helps flatten that learning curve safely.
That's the goal. It turns something potentially overwhelming into manageable steps, building confidence and competence faster and hopefully with fewer complications along the way.
And it's clear these rules aren't just about blindly following steps. They demand a really deep understanding of the anatomy, right? The why, the triangle.
Oh, completely. You have to understand the why behind each rule, the anatomical basis. It requires executing each step with careful, deliberate technique. It's informed action, not just rote memorization.
Thinking critically about each move.
Yes, why am I dissecting here? What am I trying to protect? What's the target? It cultivates a more mindful, skilled surgeon.
So how do we ensure this level of understanding and technique spreads through the whole surgical community?
Well, adopting and really sticking to standardized guidelines like these is a huge part of the answer. They're invaluable teaching tools. They provide that roadmap for learners.
And benchmarks for experienced surgeons, too.
For sure. Benchmarks for continuous improvement, a shared language, consistent evaluation, fostering that culture of peer learning and refinement. It's about building a system focused on safety and excellence.
So, for someone listening, maybe not in medicine, they might still be thinking, okay, interesting, but why should I care about hernia repair rules?
That's a fair question. I think it matters because it demonstrates a universal principle, really.
Which is,
How complex fields, high-stakes fields, break down incredibly challenging tasks into manageable, evidence-based steps to improve outcomes.
you see it in aviation, engineering.
Exactly. Precision, clarity, standardization in any environment where mistakes have serious consequences. These things lead to superior, safer results. These rules empower surgeons, yes, but the underlying principles apply much more broadly.
Turning complex knowledge into repeatable, safe action.
That's it. Providing a blueprint for mastery, for achieving consistently better results. It's a powerful lesson in how structured thinking can overcome difficulty.
Well, that wraps up our deep dive into the 10 golden rules for safe, minimally invasive inguinal hernia repair. We've seen how these guidelines, rooted in anatomy and experience, really can transform a complex procedure.
Making it safer, more reproducible, more teachable, benefiting everyone involved, teachers, learners, and especially patients.
Absolutely.
And maybe it leaves you with a final thought to consider. If this kind of clear, step-by-step golden rules approach can so profoundly improve safety and consistency in a field as demanding as surgery, what other complex challenges or steep learning curves in your own life, your own work, could benefit from being broken down in a similar way? How could you apply that power of systematic thinking, those principles of clarity and standardization, to master whatever your next challenge is?